Hi friends, welcome to this video. In this video, I'm going to discuss about cardiovascular system examination. Examination is a very important point in your exams because in short case also you are going to examine, in long case also you are going to examine. So pay close attention. I have written all the important steps which you should carry out while doing an examination of a patient who is labeled as cardiovascular system case. Right. So coming to general examination, I'll discuss the proforma first, then I'll discuss the individual components in detail. Okay, so coming to the general examination, patient is conscious oriented, right? Height, how many centimeters you have to measure, weight, and then BMI, and you have to describe about the Taylor icterus cyanosis, clubbing, lymphadenopathy, and pedal edema. Vitals, you have to tell pulse is 80 per minute or regular, high volume or no specific character. No radial or radiofemoral delay, condition of the vessel wall is normal, all peripheral pulses felt. So while going through this, you will understand that we have to check the regularity, volume status. Okay, volume status can be indirectly given by the blood pressure measurement, so measure blood pressure accurately, right? Then condition of the vessel wall, right? Condition of the vessel wall is basically by palpating the vessels. Okay, and you have to roll the vessel and see whether it is collapsible or compressible. And radial or radiofemoral delay by comparing the pulses, and then all the peripheral pulses. You should know how to measure, how to check the pulses. Okay, right. And if there is irregular rhythm, in that case you have to check for this pulse deficit. You have to measure the heart rate and the pulse rate. There will be difference for sure, and that difference you have to mention as pulse deficit. Okay, and blood pressure you have to measure in all four limbs, very important. Okay, and respiratory rate you have to write normal rhythm and abdominal thoracic type in case of males and thoracoabdominal type in females. And temperature you have to mention. So you should always have a thermometer. Okay, if the examiner asks whether you check temperature, you can say yes, and you can show the thermometer as well. So pickle and cardiovascular system, what are the relevance, clinical relevance? Yes. So anemia can occur. Where do anemia can occur? In cardiovascular system. So anemia can occur in infective endocarditis. Okay, and anemia can per se cause a congestive cardiac failure. Okay, and icterus can occur in once again right heart failure or a congestive heart failure. What happens? There is congestive hepatomegaly. Okay, your painful, tender, pulsatile liver can be there. Okay, and that can happen in tricuspid regurgitation as well. So patient have an ischemic hepatitis. Okay, you remember nutmeg liver in pathology? Yes, chronic venous congestion. That can lead to icterus. Okay, and cyanosis, cardiac failure will lead to peripheral cyanosis usually. Peripheral cyanosis. Okay, why peripheral cyanosis? Because of the peripheral vasoconstriction in a poorly functioning heart. Whereas congenital cyanotic heart disease can cause a central cyanosis. Okay, and lymphadenopathy, there is not much significance or relevance here. And pedal edema is very important. Okay, there are two types of pedal edema. One is a slow edema and fast edema. Okay, slow edema takes more than 1 minute to recover back to the normal skin, and if it disappears within less than, if you are pitting the skin, okay, you have to give pressure behind the medial malleolus. If it takes more than 1 minute, then it is due to your heart failure, whereas less than 45 seconds can suggest a hypoproteinemia. Okay, so these are the clues which you can get with the help of this pickle in cardiovascular system. All right, it's coming to JVP. We have to know all in everything about JVP, which will be discussed in a separate module. And you can check for the external markers of atherosclerosis. Basically, you can check for tendon, xanthoma, and periorbital region. There can be xanthelasma. Skin tags and acanthosis nigricans can be suggesting an insulin resistant state. Infective endocarditis, external markers can be anemia, jaundice, splinter hemorrhages, Osler's nodes, or Janeway lesions. External markers of syphilis can be Argyll-Robertson pupil, alopecia, and gummatous lesion. And external markers of congenital heart disease can be an abnormal facies. Okay. Then hypertelorism, low set ears, and webbed neck. Okay, so webbed neck can be in Down syndrome. Okay, where do you get Elfine faces in what? Supravalvular aortic stenosis patients with Elfine phases. Okay, that is Williams syndrome, and you should check for peripheral signs of aortic regurgitation. Okay, that we can see in the separate module. Okay, coming to the inspection. Chest wall appears symmetrical, trachea appears to be in midline. 3 points are very important: precordial bulge, apical impulse, and scars. Okay, my professor used to teach me there are 3 points which you should check in inspection, which includes JVP, okay, apical impulse, and your precordial bulge. Okay, and 3 things he used to tell in palpation. One is a thrill, another is a heave, another is a palpable P2. Okay, and 3 things in auscultation: heart sound, extra sounds, and murmurs. Okay, so these are the three points which you can remember. You should never forget. Okay, and it is very important for a patient whom you are examining as a cardiovascular case. Okay, this is the proforma, complete proforma. So chest wall appears symmetrical, trachea appears to be in midline, precordial bulge, apical impulse, kyphosis or scoliosis, visible pulsation, no other visible pulsations you can mention, and dilated veins or scars. So visible pulsations can be in aortic aneurysm or dilated pulmonary artery. Okay, these are the conditions which can produce a visible pulsation in specific areas. In the epigastrium, it can be due to RV enlargement, okay, RVH, okay, sometimes due to hepatic pulsation, okay, as well. Okay, sometimes due to aortic pulsation. Okay, patients with aortic aneurysm, sometimes lean individuals, that it can be normally visible as well. And coming to palpation, trachea you can confirm to be midline. Apex beat, you have to mention apical impulse in inspection, I for inspection, and apex beat in palpation. Okay, and parasternal heave, palpable P2, no epigastric pulsation, and no tenderness. Okay, so the important things to be noted are apex beat. Of course, apical impulse you are noting in the inspection, so apex beat you will do it. Then thrill, heave, and palpable P2. These are the 3 important things which you should note in palpation. Coming to auscultation, you have to go area wise from the mitral area, then the lower left parasternal area, that's also called as tricuspid area. Okay, then you can go to your above, that is pulmonary area, and to a right, that is the second intercostal side, left side, second intercostal space, left side is your pulmonary area and right side is your aortic area. So we have to go in a sequence which is also called as inching method. Inch by inch you can move from the mitral area to the tricuspid area, to the pulmonary area, and to the aortic area. Okay, so you have to mention like this: first and second heart sounds are heard, S1 is loud. This is a case of mitral stenosis. The classical description: opening snap is present, a low pitched, rough, rumbling, mid diastolic murmur of grade 3/6 heard with the bell of the stethoscope in left lateral position when the breath held in end of expiration. See the description. It is very important to describe the murmur properly. That creates a good impression in the examiners, and you are expected to explain each and everything. Okay, and you can mention no other added sounds which include S3 or S4. Then you can go to the lower left sternal area. So that is tricuspid area. Once again you can mention the same: first and second heart sound heard, no murmurs or added sounds. So what about percussion? Did you discuss about percussion? No. Did we discuss? Nothing. Why? Respiratory system, percussion is mandatory, whereas cardiac, CVS, percussion is not mandatory. It of course helps in identifying a pericardial effusion if there is discrepancy between the percussing the borders and the palpable apex beat. It can tell you a pericardial effusion. But percussion sometimes can lead to embolization. That's what the theory is, and so it is avoided. Okay. Pulmonary area, again, first and second heart sounds heard, loud P2 is heard, A2 P2 split is narrow. See, this is very important in pulmonary area. When you describe about pulmonary area, you have to always tell about the split. Without telling the split, the pulmonary area auscultation is not over. Aortic area, once again the same, first and second heart sounds heard, no murmur added sounds. Second aortic area, which is also called as Erb's area. Okay, Erb's area. Very important, especially in patients with aortic regurgitation, where the aortic regurgitation murmur, the early diastolic murmur, is best heard in Erb's area. Okay, so finally we will come to a diagnosis. If you are examining as a long case, you have to check for the other systems as well. For example, RS, bilateral vesicular breath sounds, no added sounds. Abdomen soft, there is no organomegaly. Why organomegaly? Because hepatomegaly can be there in a patient with your right heart failure, right? Then CNS, you can tell no focal neurological deficit. Why CNS? Because thrombus can be there, right? Thrombus can be there in the heart, which can embolize, can lead to stroke. Okay, so and paradoxical emboli can also be there. From DVT, it can go to the right heart. From septal defect, ASD can go to the left heart, and go into systemic circulation can lead to stroke. So these are the things which you should be adding in a patient with if you are presenting as a long case. Whereas short case, you can just straight away go to the diagnosis: acquired rheumatic valvular heart disease, severe mitral stenosis, patient has sinus rhythm, patient has pulmonary hypertension, no future suggestive of congestive cardiac failure or infective endocarditis. This is your complete diagnosis. Okay. So if the patient is in atrial fibrillation, you can mention here patient is in atrial fibrillation. Alright. So coming to the individual components. Okay. So about pallor, how will you examine pallor? So daylight, avoid the lower eyelids, ask the patient to look upwards, look at the palpable conjunctiva. Other sides include tongue, soft palate, palms and palmar creases. Nail beds lack diagnostic yield. Okay, but although we often check for nail beds, it lacks diagnostic yield. You have to comment as pallor, present or absent. Okay, so if the palmar crease is pale, what does it tell you? Can we tell that the patient has this much hemoglobin after looking at the palmar crease? If the palmar crease is pale as the surrounding skin, then the hemoglobin is less than 7 gram per deciliter. If the patient is having polycythemia, there will be flushed appearance. Okay, and if the polycythemia is there, the flushed appearance there only in the head and neck, okay, then you can suspect a superior vena cava syndrome. Icterus. Once again, adequate daylight, ask the patient to look down, look at the sclera. The conventional teaching was bulbar conjunctiva, though it is not specific. Basically, sclera has lot of elastin, which has affinity towards the bilirubin, so you can pick easily. Okay, other areas to look are soft palate, palm and skin. Icterus, you can commit as present or absent. Okay, so there is a mnemonic LOG. Okay, so based on this LOG, we can classify whether it is a hemolytic or hepatic or obstructive. Okay, the light or lemon yellow. It's lemon yellow, orange yellow and greenish yellow. Okay, so lemon yellow. Okay, then orange. Okay, then greenish yellow. So these three tells whether lemon yellow it can be due to hemolytic, and orange can be due to hepatic. Okay, hepatic, and greenish yellow it can be due to obstructive. So how much should be the bilirubin to detect clinically? It should be more than 3 milligram. Okay, to become obvious. And if a patient is having yellowish discoloration all over the skin except the sclera, what will you think about? It is, the diagnosis is hypercarotenemia. It can be due to excessive ingestion of carotene containing vegetables, especially in a patient with impaired metabolism. For example, a hypothyroid patient who has impaired metabolism takes lot of carotene, then it can lead to hypercarotenemia. You can differentiate by looking at the sclera. Sclera will not be icteric in a patient with carotenemia. Alright. So next, coming to clubbing. Basically you can view tangentially. See, take your finger, you just view. How is it? Okay, so tangential view or a Shamrock sign. Okay, you can take your fingers, both of the fingers together and keep like this and check for your Shamrock sign, or you can elicit a fluctuation. Okay, so what is clubbing? Basically it's a selective bulbous enlargement of the distal portion of the digit due to increased subungual connective tissue or soft tissue. So interphalangeal depth ratio is a thing which we can take for identifying. So basically this area, okay, this area should be thinner than this area. Okay, if it is, this area is more thick, okay, more thick, then it suggests clubbing. Okay, and the angle, nail fold angle, if more than 190 degrees, okay, this angle, if more than 190 degrees is equal to clubbing. Okay, and if Shamrock window, this window should be there. Okay, if window is absent, that is also equal to clubbing. So these are the findings with which you can diagnose a clubbing. Okay, next, this is the fluctuation test. Thumb should support the finger pulp. See, thumb is below the fingers, and forefinger should elicit the fluctuation. See, forefinger is eliciting fluctuation, and the other finger will feel the transmission of the fluctuation. Okay, so thumb below the pulp, forefinger should elicit the fluctuation. Alright. Look for widening and tenderness of ends of long bones. This diagnosis is hypertrophic osteoarthropathy. It can occur in malignancies. Okay, where the long bone ends also will become wider and tender to palpate. So these are the conventional grading of clubbing. Obliteration of angle between nail and nail bed and positive fluctuation test. Parrot beak appearance, drumstick appearance, and hypertrophic osteoarthropathy. So grade 1, 2, 3, 4. Okay, so this is the conventional grading of clubbing. If clubbing is present, we can commit whether it is unidigital or pan-digital. Okay, unidigital means single finger or pan digital. Okay, and grade also you have to mention. Okay, so what are the causes of unilateral clubbing? So one side only, can be due to aortic aneurysm, brachial arteriovenous fistula, and your Pancoast tumors. Okay, and the most important theory behind clubbing is proven is platelet derived growth factor, PDGF. Okay, there are a lot of theories, humoral theories there. Okay, and this is the most accepted explanation for clubbing. And what are the causes of unidigital clubbing? Can be your tophaceous gout or sarcoidosis or trauma. So cyanosis. How to examine cyanosis? You have to ensure adequate daylight, and sites to examine includes tongue, oral mucosa, lips, cheeks, earlobes and tip of nose, and hands and nail beds. Okay, so you can commit cyanosis present or absent, whether it is central or peripheral. Okay, peripheral cyanosis, only the extremities will be cyanosed. Okay, so why we are checking the skin? Okay, skin is thin, and in these areas only. Why these areas only? Because in these areas skin is thin and has numerous capillaries. And central cyanosis, if a patient is having central cyanosis, okay, saturation will be less than 85%. Okay, if you give 100% oxygen, okay, if you give 100% oxygen, central cyanosis will improve. Okay, the saturation will increase. Okay, if you give 100% oxygen, especially in a patient with central cyanosis. But in peripheral cyanosis, this will not happen. Okay, and in peripheral cyanosis, the saturation can improve after warming the extremities. Basically, it's a peripheral cyanosis because of a vasoconstriction in a patient with shock. Okay, so if you warm the extremities, there will be vasodilation and the saturation will improve. Okay, so now coming to the causes of central cyanosis. Decreased arterial oxygen saturation, which can be due to high altitude. Okay, that is hypoxia and high altitude, and impaired pulmonary function like alveolar hyperventilation, ventilation perfusion mismatch, or impaired oxygen infusion. Anatomic shunts like cyanotic aneurysm, pulmonary arteriovenous fistula, and multiple small intrapulmonary shunts. Okay, these are the causes of central cyanosis. And remember, hemoglobin abnormalities can also cause central cyanosis. What are the hemoglobin abnormalities? Methemoglobinemia. Okay, can occur in certain poisons. Okay, and in that case, what happens is the saturation will remain at 85% only. And when you expose the blood, if you take a blood sample and expose to oxygen, it will be turning to chocolate brown. Okay, so this is a classical finding in methemoglobinemia, and the treatment of choice is methylene blue. Okay, we have seen a lot of patients with methemoglobinemia due to poison ingestion. Okay, and there are other conditions called sulfhemoglobinemia and carboxyhemoglobinemia. Carboxyhemoglobinemia can occur in smokers, where there can be decreased saturation. So causes of peripheral cyanosis include reduced cardiac output, cold exposure, and redisposition of pulmonary blood flow from the extremities. So these are the causes of peripheral cyanosis. So what is differential cyanosis? Okay, so like upper limbs are absolutely normal, there is no cyanosis, but lower limbs is having cyanosis. So what is the physiology in PDA? Any idea? So what happens is the PDA is basically present in fetus. Ductus arteriosus is present in fetus, which connects the aorta to the pulmonary artery. Okay, and as soon as the baby is born, it should close within 3 days duration. Okay, anatomical closure, physiological closure is there. If suppose the closure is not there, okay, there is continuous shunt. Initially, the blood flows from the left side to right side. Okay, even in ASD, VSD, this only happens left side to right side. And the PDA connects aorta to the pulmonary artery. Okay, and blood flows from the usually it will be after the subclavian. Okay, your right side common carotid is there. Your left side subclavian is there. After the subclavian, then there will be your brachiocephalic is there, then subclavian is there. So after the subclavian, there will be connection, okay, to the pulmonary artery to the aorta. So after these three, okay, this pulmonary artery will merge with the aorta. Okay, so this side your left side, right side. Okay, so there is a shunt. This is the PDA. Okay, which connects the pulmonary artery to the aorta. Initially, aorta's blood flow will come to this area. Okay, there will be no cyanosis. Whereas when the pressure in the lungs increases, the systemic circulation, that condition is called as Eisenmenger syndrome. Eisenmenger syndrome. So when a patient's pulmonary circulation increases the pressure more than the systemic circulation, that is called Eisenmenger syndrome. That will lead to right to left shunt. Okay. Initially was the left side of heart, the pure blood to the impure blood shunt was there. Okay, through the aorta. But what happens later is there will be shunting from the right side to the left side. Okay. See. Later what happens? The impure blood goes down. Okay. And above the pure blood is there, but it merges with the impure blood and going the becomes the lower extremities become cyanosis. Okay, above pure blood is there, but it merges with the impure blood which is flowing because of the right to left shunt. Okay, so in that case the lower extremities will be cyanosed. That is called differential cyanosis. Upper extremities are absolutely normal, whereas lower extremities are cyanosed. Alright, where do you get intermittent cyanosis? Yes, where do you get intermittent cyanosis? Intermittent cyanosis can happen in Epstein's anomaly. Okay, Epstein's anomaly. Right, coming to lymphadenopathy, lymphadenopathy, I'm not going in depth and it is not very important also, but just to highlight and just to revise your knowledge, I just put the points. So cervicofacial area and axillary area are important. Patient should comfortably approach the patient from behind, flex the neck forwards, ask the patient to incline to the side of examination. For example, if you examine the right side, okay, then you have to incline towards this side. Whereas if you examine the left side, then you have to incline towards ask the patient to incline towards the left side. Palpate for the lymph nodes on same side. Then occipital, posterior, auricular, preauricular. These are the different groups of nodes which you should check for. Where do you get short T lymph nodes? Yes, short T lymph nodes in syphilis, lead shot like. Matter lymph nodes in tuberculosis, and rubbery in lymphoma. So these are the characteristic points which you should know about lymphadenopathy. Okay, so how to approach the axillary lymph nodes? You have to approach from anteriorly. Okay, from the front, right hand in the patient's left axilla and vice versa. Palpate the anterior axillary fold. Palpate the lateral axillary wall using your left hand for patient's left side. Okay, so right hand for the patient's left axilla. Okay, you have to take hand from here and left axilla. But when you want to palpate the lateral axillary wall, you have to use your left hand for the patient's left side. Okay, and what does this signify? Can anyone tell about this? What examination is going on here? This picture. And what is this? This is your epitrochlear. Epitrochlear. Okay, lymph node examination. What is this? This is very important. Okay, especially in RS cases. Scalene lymph node, where you will insinuate your finger between the two heads of the sternocleidomastoid. Okay, two heads of the sternocleidomastoid, and you can check for nodes. Okay, it is earlier to involve in tuberculosis. So scalene node examination is very important. Okay, so you go behind the patient, insinuate the finger between the two heads of the sternocleidomastoid, and after asking the patient to turn towards the side of examination. Okay, right? That's very important. So you have to compare the nodes with the contralateral side, assess the side size, determine whether the node is fixed to surrounding tissue or the skin, check the consistency and check for tenderness. Okay. Next, coming to our topic, it's pedal edema. You can apply pressure with the help of thumb. Firm pressure should be applied for 5 to 30 seconds. Sides, you have to apply both sides behind the medial malleolus, sacrum and malar bones. Okay, so medial malleolus is the most common side basically, because when the patient is ambulant, the fluid gets accumulated in the lower limbs. Whereas if the patient is bedridden, you have to check for presacral edema. Okay, and you can also check for malar bones, above the malar prominences. If there is any edema, you can check. And you have to commit whether it is a pedal edema present or absent, pitting or non-pitting, and bilateral or unilateral. So how to demonstrate slight edema? You have to press on the skin on a bony area for 10 seconds with at least 3 fingers and slightly spread apart. You can see valleys. Okay, see, if you press with 3 fingers, there will be slight elevation. So this you can check in a patient with slight edema. So as described already, slow versus fast edema. Slow edema, pitting remains for more than 1 minute, it is equal to congestive cardiac failure. Fast edema, pitting disappears less than 40 seconds or 45 seconds, it is almost due to low albumin level. So coming to BMI, this is the Asian cutoff for BMI, this is given on your McLeod's. Okay, so the formula is weight in kilogram divided by height in meter square. Less than 18.5 is underweight, 18.5 to 22.9 is normal for Asians. Okay, for Europeans or like other population, it is up to 24.9 is normal, but for Asians, it is up to 22.9. And this is overweight and obese and morbidly obese. More than 30 is morbidly obese. Okay, so phases, abnormal phases, I would like to tell about mitral phases, because mitral stenosis is a common case in our exams. That is the most important or most common diagnosis. As soon as you approach a CVS case, the diagnosis will be mitral stenosis. Okay, So these are pinkish purple patches on cheeks. Basically, due to low cardiac output and mitral stenosis produces vasoconstriction. Okay, and peripheral cyanosis is often seen lips, tips of nose and cheeks, and occasionally with these there will be malar flush because of vasodilation in the malar area. Okay, so these are the characteristic appearance of mitral phases. Okay, next most important point for examination is your precardial bulge. Your chest asymmetry, everything will be discussed in the respiratory examination. Whereas precardial bulge is very, very important. So how will you examine for the precardial bulge? Patient should be in supine posture. Go to the foot end of the patient. Observe the chest wall at the level of chest wall. So at the level of chest wall means you have to kneel or sit at the level of chest wall. So if the chest wall is lying like this, you have to see whether there is any elevation. Okay, precardial bulge. So just I'm just showing you. So if there is slight elevation, okay, in the left parasternal area, then I'm observing from the foot end of the patient. Okay, then it is suggests a precardial bulge. So precardial bulge means there is some problem in the heart which has happened even before the ossification. And the ribs will ossify around 18 to 25 years. So if there is precardial bulge, then it indicates a longer duration, early onset cardiac illness. Okay, right. Then apical impulse. So I told already apical impulse is an inspectory finding. So patient in cardiac bed, nothing but bed with reclined at 45 degrees. Sternal angle, that is the angle of Lewis corresponds to second intercostal space. And you have to identify the visible pulsation below the left nipple. Try to approximately calculate the ICS, intercostal space, and comment. Okay, basically impulse doesn't carry much significance. It's just an inspectory finding. So you need not worry. Okay. So basically the fingertips or the pulp of the fingers are usually, this pulp of the fingers is usually used for palpating the pulsations. Okay. Whereas this area, so this area is for your thrill. Okay, above the metacarpophalangeal joints, and this area, the heel of your hand, is for your heave, parasternal heave. Okay. So scars, what are the scars which you can find in cardiology cases? One is a midline stenotomy scar, which can be due to a CABG, that is coronary artery bypass surgery. Next, even in aortic valve replacement or any valve replacement surgeries, this is the midline stenotomy scar is done. Okay, and left submammary scar in case of mitral valvotomy. This is all done in older days. Now there is percutaneous balloon mitral valvotomy. So PMBV. So recently we are not using this incision, the mitral valvotomy technique. And infraclavicular scar can suggest a pacemaker or ICD implantation. There will be a bulge. Okay, because the mesh will be kept in the subcutaneous pocket. So that can be visualized. Coming to apex beat. What is apex beat? Very, very, very important. Most lateral and inferior portion where the cardiac impulse can be felt. Most lateral and inferior portion where the cardiac impulse can be felt. Okay, because there are a lot of pulsations which can be seen. Sometimes it can be prominent also, but the apex beat is the most lateral and inferior. Okay, and it is usually located in the left fifth intercostal space at or medial to the mid-clavicular line. Okay, half an inch medial to the mid-clavicular line. So sometimes at the mid-clavicular line can be. And it is usually smaller than 2 cm or 0.8 inch in diameter. Moves quickly away from the fingers. Best appreciated at end expiration. Okay, when the heart is closest to the chest wall. You have to count from the second intercostal space. Basically, you have to keep one finger in the apex, and then with the other hand, okay, keep one hand in the, you have to palpate the apex beat. Keep one finger exactly at the apex beat area, and you have to use the other hand for counting the intercostal spaces. Okay, so when I was doing my post graduation, I was telling my professor that this apex beat is at the 6th intercostal space, half an inch lateral to the mid-clavicular line. I was confidently telling. So my teacher told, your professor told, you just examine and show me how it is, and he wanted to verify. Okay, he wanted to check. What I did is, I didn't palpate the apex beat when my professor was seeing me. I just started counting the intercostal spaces from above. Okay, I got a good beating in my back. Okay, so he told, always you have to keep one hand in the apex beat, and using the other hand you have to count the intercostal spaces. Otherwise you may get misled. So that is very, very important. Okay, and there is one important pulsation, systolic retraction of apex beat. Systolic retraction, which is also called as broad bent sign. Broad bent sign that happens in constrictive pericarditis. Okay. And where do you get double apical impulse? Double or triple or quadruple. Okay. So double apical impulse can be seen in LV aneurysm and HOCM. Triple cadence or triple ripple apex beat is seen in HOCM. Some people will call quadruple also for HOCM. Okay, so triple cadence or triple apex beat is seen in HOCM. Okay, very very important, such a hypertrophic obstructive cardiomyopathy. All right. So place the right hand flat over the pericardium to obtain the general impression of the cardiac impulse. Okay, so you have just take your hand, and then locate the apex beat by laying your fingers on the chest parallel to the rib spaces. If cannot be felt, ask the patient to roll onto the left side. Okay, identify the LV impulse when the breath held in expiration. First with the pads of several fingers, then you can localize with the tip of single finger. Okay, this is a mixture of points from MacLeod and Perloff. Okay, so basically MacLeod suggests that you can just examine in supine posture only in a 45-degree angulation, then you can make them to turn if you are not able to get a proper apex beat. Okay, so what are the types of apex beat? Normal apex beat, you know, then tapping is there, heaving is there, hyperdynamic is there. Tapping apical impulse or apex beat is nothing but a palpable S1. It lasts for very few duration, just hits and goes. This is what the conventional teaching is. It just hits and goes. Okay, that is tapping apex beat. Heaving and hyperdynamic, what are the significance? Both the heaving, the timing is increased. Okay, increased duration that will hit. Whereas hyperdynamic, it is normal duration. Amplitude will be increased in both heaving and hyperdynamic. Duration is more than 2/3 of the systole, whereas hyperdynamic it is less than 2/3 of the systole, and occupies only one intercostal space in heaving, whereas more than one intercostal space in hyperdynamic circulation. The causes include pressure overload like aortic stenosis and hypertension, or volume overload in hyperdynamic circulation like AR, MR and VSD, aortic regurgitation, mitral regurgitation and ventricular septal defect. Basically, volume overload conditions can produce a typical symptom called palpitation. Okay, and these volume overload conditions can also produce a hyperdynamic circulation. Okay, usually left ventricle enlargement will lead to shifting of apex beat down and outwards. Okay, so LV enlargement, not LVH, this hypertrophy. LV enlargement, especially due to hyperdynamic circulation, can lead to shifting of apex beat down and out, whereas right ventricle enlargement, okay, or RVH can lead to just shifting of the apex beat laterally. Okay, there will be no downward shift, but only laterally the apex beat will shift. Okay, now coming to the next most important area, that is thrill. So patient in cardiac bed reclined at 30-degree or 45-degree angulation, palpate with the palmar surface over the metacarpophalangeal joints. So pulsations you will feel with the pulp of the finger. Okay, thrills you will feel with them over the metacarpophalangeal joint, and heaves with the heel of your hand. If thrill is present, you have to commit the murmur as more than or equal to grade 4. Okay, very important point. There should be a coincidence, like if you are committing thrill, then the murmur is more than or equal to grade 4. Okay, and what else does thrill suggest? Thrill is nothing but a palpable murmur. Remember that it is nothing but a palpable murmur. Okay, and thrill signifies that the problem is organic. It is not functional, it is organic. If the valve, there is in the mitral valve, there is a murmur which you doubt whether it is organic or functional. Okay, because even in mitral regurgitation there can be mid-diastolic murmur. It is, you know, you will feel how in mitral regurgitation only there will be pansystolic murmur. You can think like that, but in severe mitral regurgitation, what happens is a lot of blood will go into the left atrium and it again comes down during the diastole of the ventricle. Okay, so that will produce large amount of blood is going into the left atrium and again it is coming down during the diastole. That can produce a mid-diastolic murmur. Okay, but thrill can never be there. That is a functional murmur. Okay, whereas mitral stenosis, thrill can be there, grade 4 can be there. Okay, and that thrill indicates that the murmur is from the valve problem. Okay, per se, it is because of the mitral stenosis, like that. So the organic etiology can be conveyed by the thrill, presence of thrill. And parasternal heave, again patient's cardiac bed declined 30-degree angulation, heel of the hand. Okay, this is one concept. Heel of the hand can be kept, and pen or pencil can be kept. If the heave is very feeble, then you can keep a pen or pencil, or 3 fingers in the second, third and fourth intercostal space. In the intercostal space you can keep your second, third and fourth intercostal space. Second, third, fourth intercostal, just keep it in the intercostal space and feel. Okay, otherwise some have suggested that you can take the ulnar border. Okay, your ulnar border you can keep in the parasternal area and check for the parasternal heave. Okay, next most important thing to be discussed is palpable P2. Patient in supine posture, place your finger in the second intercostal space close to the sternum. Palpable pulsation indicates palpable P2. Okay, so what is shock? What is shock? Okay, so shock in cardiac your cardiac Palpation. Cardiac palpation is your palpable heart sounds. Okay, palpable heart sounds. So palpable heart sounds are called as shock. Okay, then so these are the parasternal heave grading. Grade 1 is visible but not palpable, and grade 2 is visible, palpable but obliterable. If you compress, the heave is not much. Okay, and grade 3 is visible, palpable but not obliterable. Okay, grade 3 is severe parasternal heave. Parasternal heave usually occurs because of right ventricular hypertrophy. Sometimes it can be there due to left atrial enlargement also. Okay, so coming to the heart sounds and murmurs, you should know the areas of auscultation. Okay, mitral area, that is at the apex, lower left sternal area, which is also called as tricuspid area, then pulmonary area, aortic area, second aortic area, which is also called as Erb's area, which is third intercostal space, left side close to the sternum. Carotids you have to check, and axilla you have to check. Okay, and always remember the rule is high pitched sounds. Okay, high pitched sounds occur usually in high gradient. For example, aortic regurgitant murmur is high pitched. Aortic stenosis murmur is mixed frequency, whereas aortic regurgitation murmur is high pitched because the gradient is more. Okay, so this HD, remember, always remember HD. Okay, you know HD, high definition, right? So high frequency murmurs or sounds will be heard by the diaphragm of the stethoscope. Okay, H for high frequency, D for diaphragm, whereas low frequency will be heard well with the help of bell of the stethoscope. Okay, so very important points. And remember, all the right sided heart sounds will increase with inspiration. RIGHT, the word itself is having the mnemonic R for right and I for inspiration. Okay, so all the right sided heart sounds increase with inspiration, except there is an exception which is often asked as MCQ as well, that is your pulmonary ejection click. Okay, all others will increase with inspiration. Similarly, left sided sounds, LEFT, the mnemonic is there, L for left and E for expiration. All the left sided sounds will increase with expiration. Okay, so regarding heart sounds, you can comment on the normal heart sounds first and second heart sound heard, comment on the intensity. Okay, whether it is loud, S1 is loud, like that. Then you can comment about the additional heart sounds, S3 or S4, opening snap or ejection click. You can tell if it is present or absent. Then comment about the murmurs. Murmurs, you can tell about the pitch, quality, respiration, radiation, site, timing, grade, whether it's systolic or diastolic, right? Any positional changes with what of the stethoscope, with the bell of the stethoscope or the diaphragm of the stethoscope you are auscultating. So these are the things which you should comment in a patient who is having murmur. Okay, so just to tell about the low pitched sounds and murmurs, third heart sound, fourth heart sound, and mid diastolic murmurs. So these are the classical low pitched sounds and murmurs in cardiac auscultation. And high pitched sounds and murmurs are first heart sound, second heart sound, clicks, snaps, anything else, okay, which you can encounter is your high pitched sound and murmur. And so with this we have come to the conclusion. So examination is very important. Okay, and in examination I would be highlighting some things in the next module. Basically I didn't tell much about the pulse, okay, and blood pressure, okay, then JVP, okay, and heart sounds and murmurs. So these are the things which are very important. Okay, you should have a understanding why they occur, how they occur. So I will be taking you to another module for discussing these things. Okay, apart from that, have a understanding how to examine the patient well. Okay, remember, always the gold standard is always stand in the right side of the patient. Okay, remember, if you are examining a female patient, a female attender should be there. A girl who is examining a male patient, a male attender should be there. These are the rules, golden rules which should be followed. Sometimes in examination, the staff nurse will come and stay with you when you are examining. So, and have a proper sequential idea of how to examine. Okay, so that will help you to pick the diagnosis very easily. So with this we have come to the conclusion. Thank you very much.